I was asked to talk about my philosophy, approach, strategy, technique when it comes to eyelid rejuvenation, especially the lower eyelids. I've done a lot of virtual consultations about this topic. I think it's worth to re-explore this idea one more time and give you my 2023 version of the previous virtual consults I've given over the last few years. So the first thing I want to talk about, there's been a migration over the last couple years, is I've really moved away from fillers around the eyes. I've done every type of filler from Bellafill to Radiesse to Sculptra to Restylane, Juvederm, etc. And I've found all of them to be wanting. In other words, I haven't found a great filler around the eyes. I thought that Restylane would have been my ideal choice because unlike Juvederm, there's not much swelling. Bellafill, I had some long-term granulomas I had to correct through excision. So I thought Restylane would be great. In fact, I've been using Restylane for many, many years. But now when I look at my filler results 7 years later, I've noticed I've had to dissolve quite a few of them. And the good thing is I have an ultrasound that's very guided, that I'm able to go in there and dissolve those fillers. But at the same time, it's not something ideal. And it makes things harder for me to enter the world of surgery to fix it, which I'll talk about more in a moment. But in general, I don't like to have to dissolve fillers. But the trick here is that fillers actually don't go away. We think that fillers are gone in 6 to 12 months because we Googled that and Restylane is gone in maybe no more than 18 months. I'll tell you some stories briefly. I had a lady that the last time I did fillers on her was 2010. She had an MRI in 2021. It was still there. And I had a lady that I do a lot of lip surgical corrections, and I had a lady that Restylane squirted out of her lip. And I said, hey, when did you have Restylane? I'm fixing silicone. She says, I've never had Restylane, I've only had silicone. I said, no, I know the difference between silicone and Restylane. And she says, oh yeah, in 1998, and I did the surgery in 2018, which is exactly 20 years prior. She said she had one filler of Restylane, one syringe of Restylane in Europe. So fillers do last. So a quick preamble to my discussion of surgical methods is to suffice it to say that I'm not a big fan of fillers around the eyes anymore. I've had some long-term issues which I've had to fix. So let's talk about how do I address this surgically. So first I'll tell you what I don't do. So the lower lids, I think it's a precious area. It's an area that must be managed in terms of functionality as well as cosmesis or cosmetics. I don't do a skin muscle flap. So what is a skin muscle flap? An external incision. The problem with external incision is you've got to tighten up the canthus and reconstitute it. And there's always a risk of the eyelid either being drawn up a little bit, if there's a little bit slippage, or going down, or having some problems. Because I notice everyone says, you know, if I just do this, everything smooths out. If I do this, my facelift looks great. And the problem is that honestly, it doesn't do that. And there's so much risk with an external incision that the good news, I can look you in the camera and say in 20 years, 20 plus years of surgery, doing this surgery of the lower lids every single week, if not several times a week, I have never had an eyelid malposition. You say, well, then you're not looking carefully enough. No, I'm telling you, the technique I'm doing, I've never had eyelids that look weird. And the reason for it is I don't make an external incision where you weaken it. A great analogy I use is rhinoplasty. In the old days, I used to use a Collie-Meller strut, which is a little graft to put in there, and there was a lot of variability. Now, I can actually fixate the base of the tip to the caudal septum so I get predictability. Well, there is no equivalent of that caudal septal extension graft in the lower eyelids to get predictability. So how do I work around this issue so I can avoid this problem? So it's, for me, looking at the lower lids, it's a combination of hollowness and it's a combination of eye bag. So sometimes I take out an eye bag, but almost always I add fat around the eye. So fat to me is the gold standard. I use Pure Graft, which has worked really well in terms of preventing issues with lumpiness, in terms of absorption. Now, of course, you can have some absorption with fat. It's not going to be perfect. And I counsel all my patients, don't expect to have a perfect outcome. Fat has some level of absorption. I can't quote you a percentage because it's hard to know that, but I get very, very high percentages where I would say 95% plus of my patients I'm not doing a touch-up on, which I charge very little for. But I will tell you, the small percentage, yeah, some people say, look, I just want a little bit more touch-up, and it's the case. But I counsel patients how to see this. So I sort of divide this into left and right brain perspectives. The left brain means my left and right don't look exactly. I wish every crease was gone. I wish everything was gone. A colleague of mine came up with a great saying I learned last week when I was lecturing in San Diego, which is always improved, never perfect. I thought it was a genius idea because, left brain philosophies where everything is gone, it's not going to happen. I'm just going to make it look better. So this combination of fat grafting and occasional eye bag removal is the best way to do it. Now, how do I take that eye bag out? Transconjunctivally, which means I take it from the inside of the eyelid out. Very safe, there are no stitches in there, but that way there's almost zero risk, I never say zero, but in 20 years I've never had an issue of eyelid malposition. So fat done well, I've written the landmark textbook on fat grafting in 2006, and I've seen great longevity, really safe results under the eyes. It's really just a simple idea of injecting perpendicularly under the eyes instead of parallel to get very smooth results with fat and very good durability. So this combination of a little bit of removal and a little bit of add is my go-to in terms of managing the lower lids. With the idea, as I told you, never perfect, just always improved, just never perfect. In terms of understanding wrinkles under the eyes, so for me, the wrinkles are really a combination of several things. A little light laser, a little bit of Botox, maybe a little discrete fillers. And he said, well, wait a second, Dr. Lamb, you just told me you don't do fillers under the eyes. Correct. For volume loss, no. But if there's a little bit of a wrinkle near the eye, I have a technique called dynamic fillers where I can cross-hatch that area and improve the dynamic wrinkles. So the trick, though, is not to look at that and say, I got to take all the skin away and tighten up that whole area and pull that up. You're not going to get rid of the wrinkles, okay? There's no way you can do that, and you're going to create eyelid risk in terms of eyelid malposition, so I don't do that. So for wrinkles, it's a skin problem. It is not a surgical problem. I do not want to cut it out, try to tuck up these areas. You're not going to have a good result, and you're going to have significant risk. So that's a philosophical difference. When you look at the upper eyelid, I look at it as a combination of multiple things. One is, everyone knows, a little skin removal is great. What do I do in terms of skin removal? So what I don't do is very important. Traditional way of looking at skin is that there's too much fat, there's too much muscle, there's too much skin, I'm going to take it all out of there. I think that's a problem because you're going to drag the brow down, you're going to hollow the eye out, and if you go back and look at yourself when you're younger, you do not have a hollow eye. So I only take skin out to manage the crepiness of the skin, and it's not a lot. It's just enough to make that edge not look saggy and crepey and unattractive. But I look at the upper eyelids as a combination of other factors. So one is volume loss. Now, how do I look at volume loss? This is the most confusing thing I try to explain during consultation, so you may not even get it during this video. But here's the best way to look at it. Think of the area around the eye like a skull. If you think of a skull, there's a hollow rim around the eyes. So everyone's familiar with the hollow rim here. You put fillers there, you put fat there. No one thinks about the hollow rim of the upper eyelids, but to me, it's just as prominent as the lower lid and just as deserving of treatment. So what I do is, if you look at that rim transition of the upper eyelid, just like the lower eyelid, I put fat there. So by adding fat around the eyes circumferentially 360 degrees, I'm able to manage that hollowness. You say, well, wait a second, Dr. Lamb, if you do that, you're going to make my upper eyelids heavy, and that's the whole reason I'm coming to see you. I don't want to do that, but the way I liken it is, think of it like a balloon. When a balloon deflates, it looks like I've got to take all that extra tissue out, but if you reinflate the balloon, it looks less saggy. So believe it or not, by adding that fat in there, I can actually reinflate that balloon. So it's not a gross amount, it's a little amount. Do I ever take fat off the upper eyelids? Yes. Not that common, I would say less than 10%, and it's only in the inner portion of the eye. Sometimes I see a little bulge that comes out from the inner eye, and you see this pocket sitting out there. It's not that common, but that I will take out in tandem with either skin removal, with or without fat addition. So sometimes I'm taking fat out and adding it, but it's almost always in the inner eyelid, and that's not that common. Less than 1 out of 10, sometimes really 1 out of 20 that I'm doing that on. A very simple, easy procedure. The other things that I do with the upper eyelids is sometimes I'll do a very conservative ptosis repair. Ptosis is what happens when we get older, our eyelid muscle gets weaker and it starts to actually not open as much. I do what's called a Mueller muscle resection, so I don't do an external approach anymore, which is, to me, a little bit riskier to get exactly the perfect results. But if you're looking for more than 2 to 3 millimeters of elevation, you would need an external approach. I don't bother to do that. The internal approach is done from inside. The stitches dissolve. It's just to elevate about 1 or 2 millimeters. It's not a significant amount, but it helps a little bit. The fat grafting sometimes can actually expand that area and maybe add 1 or 2 millimeters as well. So ptosis is a very hard thing to completely correct. I don't do external approaches, but that's another confounding variable to the whole equation. Brow lifts. Do I do brow lifts, and when do I do brow lifts? So I like what a colleague of mine in Los Angeles said. People lift brows more than they fall. Pardon me. So I do brow lifts, but I only lift the outer tails. I think it's too high when people look surprised. I just do a small elevation out here. I do a hairline incision to do that. I would do that in 1 in 10 to 1 in 20 patients. I think there are way too many brow lifts being performed, but if I see a brow lift that's sagging, I have a low restriction to go at, or low barrier to do that, but it's not this elevation, it's just the lateral tail being elevated. So that's the general idea of how I approach the eyelids. If you really want to know more about recovery and everything, this video could last hours. I just want to go through sort of philosophy, strategy, techniques. You sort of understand how I do things, how I stay away from unsafe elements, what my philosophy, how it's evolved, and really how to keep you safe and natural.